So, before we jump right into infant sleep staging, we should talk about the different ages that waveforms show up and what changes as infants grow because the EEG looks so much different than adults do. So, how does a fetus who is not born yet sleep? Well, we know the answer because we've monitored premature births. There's nothing nice about having a baby in the neonatal intensive care unit, but if there is one convenient thing for technologists in monitoring infants this young, is that you really don't have to scrub their skin, and they're really not going to move much to be able to take the wires off. My youngest pediatric patient was 16 weeks old post term, and I was able to check my impedance with my impedance meter so that I could just check the electrode that I just put on, and they were all fine before I plugged them into the head box. Children that young haven't been exposed to the elements, and their skin is sensitive and not tough at all. Let's get a few concepts straight. You will hear gestational age, which is how long it's been since the mother's last menstrual cycle before she became pregnant. So a gestational age of 24 weeks would mean it's been 24 weeks since the mother's last cycle. That's how long the baby's been cooking. At 24 weeks, you can't tell whether a fetus is awake or asleep. At 27 weeks, gestational age, you can tell whether the fetus is in active sleep due to their intermittent EEG activation, eye movements, and increased respiratory rate. At 37 weeks, gestational age, wakefulness, active sleep or R sleep, and quiet in sleep is differentiated. You can tell the difference. Here's the next kind of age that we need to know. So gestational age is how long the fetus has essentially been growing in the womb. Chronological age is time spent outside of the womb. Corrected age takes the chronological age and subtracts the number of weeks early that infant was born. Corrected age means it adjusts the chronological age, subtracting the number of weeks early they were born. For example, a 12-month-old who was born 3 months early would have a corrected age of 9 months. Corrected age is to account for the time they were still supposed to be inside the womb developing. 26 to 28 weeks corrected age, which is pretty premature compared to the roughly 40 weeks full term, we see discontinuous EEG, which are periods of quiescence for 8 to 20 seconds, with periods of inactivity up to 2 minutes. Quiescence is inactivity or quietness. Discontinuous EEG usually shows some low voltage, slow frequency EEG. They can also show short, synchronous high voltage delta bursts. Sleep state still can't be determined at this age. Here's a simple diagram that you should include in your notes that illustrates continuous EEG versus discontinuous EEG. When we say discontinuous, we mean the brain just doesn't show any waves except for bursts. There are still some, but it just doesn't show much. Continuous EEG is what we expect from adults. It's when the waves change but they never stop. Here's an example of discontinuous EEG in a 27-week-old infant. The flat activity are the interbursts. Here's an interburst, and then all of a sudden these delta waves show up, the bursts, and then interbursts. Around 29 to 30 weeks, the EEG should become more continuous with less interbursts of flat activity and 50% more synchronous waveforms, meaning they occur at the same time. Eye and body movements have more force and meaning, and the wake and sleep cycle may be measured. The EEG shows a few new things, namely delta brushes, which are long delta waves with beta waves riding on the wave. I've got a slide to show you what those look like. There can also be delta waves in the occipital lobe as well as sharp transients, which are just sharp waves that happen spontaneously. Here's some delta brushes. You may also hear them called delta ripples. It's almost like the baseline deflects upwards, kind of like sweat artifact, or downwards. And then you got this, it's faster than alpha, that's beta. But they're riding on these waves. Those are delta brushes. It happens after a a period of it's an interburst. Almost look like spindles riding on the wave. This is a good indicator of brain maturity. It kind of give you an estimate of how far along the brain has matured. 31 to 33 weeks, the EEG is 50% synchronous and even more continuous with less interbursts. There is now a clearly defined sleep-wake cycle. Background EEG still shows some discontinuity, but also delta, theta, and alpha. This is the background, and not other features like delta brushes, which will start to show in the occipital lobe. Because there is a clearly defined sleep cycle, we can measure active sleep versus quiet sleep. Active sleep, which we would consider more like REM, has continuous EEG, and there are eye movements and low amplitude EEG with infrequent delta bursts. Quiet sleep, which we can compare to non-REM, renders the patient very still, really paralyzed, and the eye and body movements disappear. Regular respirations occur and trace discontinue, which is discontinuous EEG. I believe that is French. Here's some more delta brushes at 32 weeks. There's also some theta waves right there, and there's some more theta waves right there. Delta brushes. See, the patient's not moving, or else these other signals would show movement. So that's not movement artifact. That is the baseline, and these beta waves are riding those big waves. At 34 to 35 weeks, the infant should show continuous EEG and synchronicity within the EEG, except for quiet sleep. Delta brushes are still there, but not as many as before. The transient sharp waves continue to be seen, and they are now showing in both hemispheres of the frontal region in both active and quiet sleep. Frontal delta activity also begins. EEG reactions to strong sensory stimuli like bright light, strobe, loud noises, or painful skin stimuli. This is related to the arousal response that naturally develops over time. By 36 to 37 weeks old, the EEG will show roughly 80% bilaterally synchronous waves, bilaterally meaning both sides or hemispheres of the brain. When the infant is awake, the EEG shows low voltage mixed frequency, LAMP. This is really the same as low amplitude, but LVMF. We're using different terminology for infants because they do have different brain processes than a normally developed brain does, and we should attempt to differentiate the two. Active sleep shows diffused delta brushes, so we know what delta brushes are. Diffuse delta means it's showing in all the regions and all the hemispheres, everywhere in the brain. Earlier we saw that occipital delta came first, then frontal deltas, and now they're everywhere. That's the progression of them. There is also a waveform called trace alternate. Trace alternate is very similar to trace discontinu, but the difference is trace alternate has a maximal amplitude voltage of 25 microvolts in the inner bursts, or relatively low activity period. Trace alternate will have inner bursts that are greater than 25 microvolts. Here's trace alternate. You can see the relative inactivity between these bigger waves in the middle. This is a collection of lower amplitude waves that are greater than 25 microvolts. These bursts of waves are also deltas, more than 75 microvolts. By 38 to 40 weeks, which is just before full term, the EEG is synchronous, and while the infant is awake, they showed continuous theta waves. Active sleep consists of continuous intermixed theta and delta waves, or continuous low-voltage irregular theta and alpha. We saw theta a little earlier with delta brushes. Quiet sleep, on the other hand, shows trace alternate like we just saw. Here's continuous EEG. That's just when there are always waves and no quiescence or cessations of waves, no flat lines. Now we have a full-term infant. So between 40 and 44 weeks gestational age, wake and active sleep both show continuous low-voltage mixed frequency. Quiet sleep shows continuous delta and trace alternate. Because of this, part of this is because the immature neurological system, the dendritic branching, is in what you may say its sapling stage, where there are many branches but very few organized or well-regulated connections. But those will grow and develop and into better connections, where the myelin sheaths will strengthen their connections. Also, even though the corpus callosum is present, the two hemispheres of the brain are still trying to connect to each other, and for that reason we see some asynchrony in the EEG. The waves won't line up with the other side of the brain yet. Remember, the corpus callosum is the part of the brain that connects the two hemispheres, and later on, if someone has trauma, damage, or is born without one at all, you will see things like sleep spindles that should occur simultaneously, but they'll happen at different times in different parts of the brain. The dominant frequency seen during wake is delta, big slow waves. You will not see PDR in the occipital signal during eyes closed yet. Again, pain and noxious stimulation can attenuate EEG. Full-term infants go by the rule of 8. 8 hours awake, 8 hours quiet sleep, and 8 hours active sleep. Incredible things are going on inside the body of an infant, but on the outside, they really don't do much. When the infant is what we would consider active awake, their eyes are open and looking around, but they really don't blink very much. They might coo and cry and have other vocalizations. And this is active awake. Let's not confuse it with active sleep. Usually, when they're awake and not drowsy, they will be moving around a bunch. Because of this constant movement, they will have an irregular respiratory rate and an irregular heart rate. If they are quiet and awake, and maybe a little drowsy, their eyes will still be open and look around, but they don't move as much. So at this point, there are 4 parts of consciousness for an infant: quiet and active sleep, and quiet and active wakefulness. For neonates or newborns, the EEG during wakefulness shows low voltage, irregular mixed frequency. Their muscles will tense up and stretch, and this can cause artifact from movements in pen blocking, which is what happened when the paper machines, which we have no more, they had no more room to move for the pens, and so they would just hold the furthest point they could. For babies this small, the transition from wake to sleep in the EEG is tough to tell. If their eyes are closed, you can pretty much assume they are asleep. Here's pen blocking. The signal is so big that it would continue either this way or up through here, through the page, because that's how high the voltage is. But the pen on paper can only go so far, and so it just holds the highest or lowest point it can. Computers can do this too, to limit how much the waves interfere with each other. This is not usually a setting that labs have, which I prefer not having them so that you can actually see how big the waves are. Sometimes the reason for pen blocking is big movements when the patient is moving around in bed, and these are so big and high in amplitude the signal is too big for what we're looking for, which are smaller voltages during sleep when the patient is sleeping. If we wanted to see a good signal for these big movements, we would have to adjust the gain or the zoom to decrease the signal size. Moving along to 2 to 3 months old, and this is chronological age, so we're taking normal term infants that have been out of the womb for 2 to 3 months. In 40% of this population, sleep onset still begins with REM. There are now 3 separate non-REM stages plus REM, like adults. Immature sleep spindles are called sleep ripples, similar to the delta brushes or delta ripples we saw earlier. This is more active sleep than quiet sleep, and the new EEG features seen are vertex sharp waves. At 3 to 6 months, we see hypnagogic hypersynchrony, which is the burst of delta waves similar to trace alternate, but the inner bursts now are just continuous EEG without so much low activity comparison-wise. The vertex sharp waves that began not too long ago have matured and are well developed, typically occurring in non-REM 1. When these infants wake up, it takes the EEG a while, sometimes 3 to 5 minutes, to return to normal awake EEG, or just their normal brain function. When in non-REM, the background EEG shows high voltage slow waves, lots of delta. They're growing. Also, non-REM 1 slow rolling eye movements appear and aid in the staging of wake versus sleep. The total time spent in REM has also decreased from 30% to 30% from 50. 3 to 6 month olds sleep between 8 and 12 hours at night, and they usually have 2 to 4 daytime naps. This is not continuous sleep. The infant still awakens a lot to eat at night. And this is classic for when parents are dreaming for the day when their child will sleep through the night, which doesn't really happen for a while. That 8 to 12 hours is still at night. Those 2 to 4 daytime naps usually are about an hour each. So you're really looking at between, I'd say, low end 12 to 18 hours, high end. Between 6 months and 1 year post-term, the EEG is still asynchronous, as are sleep spindles, which have become more frequent and can last up to 5 to 10 seconds, which is very long compared to adult spindles. Once the eyes close, the occipital derivation should show theta, which would be their PDR. You'll also start to see K complexes, vertex sharp waves in groups, but the spindles are still asynchronous. They don't happen at the same time, and they continue to be long. Staging is almost identical to adults, with the exception of no alpha for PDR. It will be slower, and the architecture will be different as well. When preparing for the study, you need to think about how much time it takes to run an infant study. Usually these patients arrive earlier in the evening than adults because they go to bed earlier and you want to get more recording time. At birth, there really is no influence from a circadian rhythm because the infant has not been entrained with daylight yet, and for the first 10 weeks it's still not established. Despite the convenience of recording naps during the daytime, evening and nighttime recordings are preferred because of the longer sleep duration at night. As the AASM and most insurance companies demand, there need to be at least 6 hours recorded. More is definitely preferred. Most physicians want at least a minimum of 400 minutes of sleep time, not recorded time, sleep time. With older infants, with more sleep at night, 10 hours recording is recommended. Some labs, however, don't care about getting a quality study, and they cut their patients loose after 6 hours of recorded time. Number one, how dangerous and rude to get someone up that early and make them drive home. Number two, that's hardly any time for the patient to get really all of their sleep. We want to get the whole picture of a patient's night. They may have more or fewer events at the very end of the night, but you never know that because you've ended the study too early. Maybe a patient has REM behavior disorder, but if they hadn't had REM yet, because they have this antidepressant that suppresses it until the end of the night, and you end that study, that was a waste of a study. With infants, they don't sleep through the night. They have feedings, which should be recorded, as well as the resultant or other spontaneous wake time. As we've talked about before, infant sleep states are different than pediatric or adults. They actually consist of wake, crying, active sleep, which is REM, we just say stage R, and quiet sleep, which we say is stage N, but we know is non-REM. There's also indeterminate, which can be scored when you can't really tell if an epic is in or R sleep or wake. Some labs will accept artifact time as well as for movement if the patient is moving around for more than half of the epoch. And this is becoming more and more scored because there's relatively new diagnostics of a sleep movement disorder where a certain amount of time is where the patient just moves so much. Like I said earlier, there aren't many things that newborns do. So when they do things, you should make note in the study, document it. Things to document on the record as they happen are if the eyes are open or closed, or if they're blinking. The mouth could be chomping, sucking, doing something rhythmic, or the infant could be pursing their lips. Also, for most of these things, you can confirm the artifact on the study that it makes. Pay attention when people or babies do things, and you can tell, like, oh, they're blinking or they're reading, and see what it looks like on the study. That'll give you a real good idea of what that stuff looks like. If the patient is looking around, you will see eye clicks or blinks depending on what they're doing. Their face could be relaxed, or they could be frowning, smiling, grunting, or have jerky startles. Take note of fine body movements like isolated limbs, like they're just moving one arm or one leg. That's not something normal, and that could indicate a neurological disorder. Babies are usually moving their arms or their legs at the same time, and they can't really lift their head yet because it's so big and their muscles haven't gotten strong enough to do anything with it. As far as vocalizations like crying, whimpering, and cooing and grunting can be seen in the snore microphone deflections. Other things to note would be sneezing, coughing, hiccups, yawns, burps, regurgitation, and flatus, or farting. Whenever the caretaker has contact with the patient, document everything. You have to document these things not only because the doctor can't always see what's going on or when they're looking at the study on the video. What if something happens to the video and it gets deleted for some reason? That happens. That's why it's a good thing to document everything the patient and caretaker does. Also, if there's abuse, you have evidence of it. Try to keep the environment in the patient's room the same, meaning don't change rooms on the infant if something's not working. Put them in a room that you know is working already and you won't have to disturb them. Some pediatrics have a real hard time going back to sleep, especially when they awaken up in a scary environment. A lot of labs have both annoying office lights as well as softer bulbs that's more enticing to sleep, and they're usually dimmable. Try and replicate what the patient's room is like at home with temperature and lighting. If you're able, keep this patient in the room furthest from all the other rooms if they're adults, so that when the adults arrive or if they leave early, they won't disturb the infant. Here's a decent summary of what the EEG looks like, very basically as a neonate develops, and I would copy this table down. Here's another small table talking about a lot of the different EEG elements that neonates show at different ages. I forgot to put in a final slide, so one more to go, and it'll be about infant staging. Quiet sleep, active sleep, indeterminate, stuff like that. Okay, we'll see you then.